So what I was going to talk about today, update on knees. So as you probably know if you've been here, I can talk about hours about knees. So I thought I'd pick up one or two topics which are current or of interest. And then at the end we'll leave quite a bit of time for general questions, because clearly you may have topics, patients, questions that are pertinent to your practice that you want to discuss. So now I thought we start with knee replacements. Knee replacements, as you know, very common. They've been around a long time. A very successful procedure, but there are lots of changes happening. From implants, how we do them, do robots have a role? You've heard about robotic assisted surgery in other fields, and it's coming into orthopedics. Then we look at some of the NJR results, National Joint Registry. I don't know if you guys are aware, every joint we do, replacement we do in the UK, patient details are entered in the National Joint Registry. They've been around since 2003, so I've been around longer. So all of my patients' details have been entered, and the patients are followed up. So there are various end points, but essentially it's a revision surgery. So if I do a knee replacement here and they're revised in Manchester, NGR are able to match from the NHS numbers so that they don't get missed. So total knee replacements, I would say that is probably one of the most successful operations that we have in medicine. We probably, if you were to rank most successful operations as a whole, cataract surgery, hip replacement, knee replacements. And in the UK we do about 100,000 a year. And last year was a bit quiet, I did 173. So we do lots of them. And it's important that if we're doing something that we're following them up. And that's where the National Joint Registry comes in. I tend to do my own scores, sort of the Oxford scores pre and post surgery. And now they've been used as a PROMS. I don't know if you guys are aware that National Joint Registry also used to publish patient-related outcome measures, and they were using the Oxford knee scores for those. So the interesting things, there have been a lot of developments in total knee replacement around implant design and how do we do it, and whether we can use newer technologies to improve on what we do. So when we did knee replacements originally, and majority of the time when we still do knee replacements, you know, we talk about anatomical alignment of the knee and mechanical alignment. And essentially, when we've traditionally done knee replacements, we rely on the mechanical alignment because we think the load goes from the hip center to the middle of the knee to the middle of the ankle. And if we put a knee replacement in situ, we want that load going through the center of the knee replacement. However, there's been a lot of interest because there was a paper 10-15 years ago from the National Joint Registry that there's up to 20% of people who are unhappy with their knees or knee replacements. Now, how we measure unhappiness is difficult. It's a subjective measurement, but people have been saying, well, it not as good as I thought, or not the one I wanted. Did it get rid of your pain? Yes. Would you have it done again? Yes. Do you want the other one doing? Yes. But it's still not quite as good. So because we're chasing this last few percentage of people, there have been innovations in how we do it and looking at implant designs. So just historically, this is very, very old knee replacements. Although those of you who've seen partial knee replacement now will know this is not really that different from the current partial knee replacements we do. But instead of doing a total knee replacement, they did 2 half knees. It seems like now our implant designs have changed, but we're coming back again to doing maybe combined partial knee replacements. And this is an example of an older total knee replacement. But these are more modern knee replacements that we have. So basically, knee replacements are resurfacing the ends of the bone, so the end of the femur and the top of the tibia. Now this is an aside here. I saw a patient, not a patient, somebody who mentioned, he said, do you know about knee resurfacing? And I thought, no, like hip resurfacing you may have heard of. So, some people are promoting knee replacements as knee resurfacing, or particularly partial knee replacements. Essentially it is resurfacing the knee, but in this modern world of marketing is how people are promoting. So this patient from Cheltenham was going to go to this doctor in Southampton because he's the only one who does knee resurfacing. And we know this guy in Southampton, we know what he does. He does no different from any knee surgeon up and down the country. But because he's promoting resurfacing, people think, well, I want to have it resurfaced, not replaced. But this is resurfacing treatment. So the interest now is how we're going to do it, what implants are we going to use, and alignment philosophies. So the alignment philosophies, if we all were to stand up and have a look, some of us are straight-legged, some are bow-legged, some are knock-kneed, and we're all variants. And if we do a knee replacement and just put them straight, one on top of the other, then you just wonder, is that the right thing? Is that the wrong thing? There's a lot of debate. But the first thing is to sort of see what the general population, what our knee phenotypes are. What do we look like? We're all different, but if we did enough of them. So this is the basic, anatomical alignment, mechanical alignment. But recently, in the last 3 or 4 years, there's been a lot of debate and discussion and research looking at our knee shapes. And it's based on the anatomical alignment and the angle or the slope of the femur on top of the tibia. So on average, we sort of say it's a 3-degree varus or slope inwards, and about 5 to 7 degrees backwards from front to back. So the one classification which you may or may not have heard of, which is gaining a lot of publicity and discussion at a lot of our knee meetings, is this something called CPAC, coronal plane alignment of the knee. So as we stand from the front, so this is just one. So varus, valgus, whatever other shapes we have. So they published this 3 years ago, 500 normal individuals and 500 arthritic knees. And they came up with this 9 different shapes that we have in the general population. And it's interesting, so if somebody is this shape and you make them that way, they might not be very happy, because if one knee is like this and the other one's different. But it's very difficult understanding what the person's classification, the alignment is first. How do we work it out? Plain X-ray, CT scans, MRI scans. This is early, but it's current thinking on knee replacements. Where we're going to go, we don't know yet, but we're not standing still. So we're trying to do something different and newer. And it differs as to what part of the world we come from. So this is essentially in Caucasian and Asian populations. We don't know about the Africans. We don't know about, when they say Asian, so are they talking about Chinese Asians origin or Indian Asians? So even in the world we live in, society we live in, I don't know, people like me are called Asians, or are Chinese called Asians. If you go to one of the private schools, the Asians are the Chinese ones. Whereas if in the general population that we live in, when they talk about Asians, they're sort of Indian subcontinent people. And we're all different shapes and sizes. So, but in the Caucasian, Asian population, we tend to be mostly slightly bow-legged or straight. And we don't know about Scandinavians, because usually very tall people, whether they're more valgus. If you look at rugby, those of you who follow rugby, so on the whole, the backs, they're slightly bow-legged, aren't they? They run fast. Whereas if you look at the second row, They're usually very tall, but slightly valgus. I'm generalizing, but there are different shapes. And it's difficult to treat a prop, a second row and a back. You would treat them differently. They would get different sort of injuries. But when we come to knee replacements, what we do works, but whether we can fine-tune that to chase that last few percentage of people who are unhappy. So, looking at an Indian population, CPAP 1 was more predominant in people who have arthritis. So one could argue, if we put them in that position, and they're already getting arthritis, the ones that we put in artificially, they might fail more. But we don't know that. Because if they're bow-legged and they're failing, the native knees are failing, and you put the new knee in that same position, will it fail more? So, and the other thing is, I mean, this is obvious statement, but male and female knees are different. And this has been an interesting debate. You may have heard of gender knees, gender-specific knees, male and female knees, because the aspect ratio medial lateral to AP in a male and female knees are slightly different. Whereas traditionally we've been putting one standard shaped knee into everyone. The interesting thing is there was a gender knee. One of the companies, Zimmer, promoted it quite heavily. So it was called basically promoting, pushing for more female patients. But the overall results were no different from the standard knee implants. So they've sort of gone out of fashion. But people are trying to improve the outcomes by trying to target individuals. So if we're going to try to put people's knees into slightly varus or slightly valgus, and how accurate can we be just with the standard conventional instruments? So the sort of knee replacement that we do traditionally using standard instruments, we can put them slightly varus or slightly valgus. 3 degrees either way, on the whole, is okay and acceptable. But sometimes you look at the x-rays and say, how did I do that? Was I asleep? And the patients are very happy. It's rare, but the patients are very happy. But if we want to try to get the alignment right, can we use assistive technologies, robotic-assisted surgery, to try to improve the accuracy? Because we hear that the robots, like car manufacturing, they can do all sorts of things much more quickly and more accurately than when we used to conventionally put the screws into cars and whatnot. So the pros for robotic-assisted knee replacement is accuracy, and these alignment philosophies. These are very much philosophies at the moment. In a room full of knee surgeons, probably 90-something% would still be doing the conventional knee replacements. But if the other guys can prove that actually putting them in slight varus or one of those CPAC type of knees, it might be better. The other thing with the robotic assisted pro is that there's less trauma, which then would mean less trauma to the knee during the procedure, less pain. They can be discharged a little bit quicker. But we don't know the long term, as it's only been going on for a few years. But the National Joint Registry were able to follow. They haven't currently published data other than from the National Joint Registry, the outcomes, but individual studies, there have been some slightly coming in favor of robotic assisted surgery. The cons are cost, they take longer in theatre, and each company has their own robots. And as you probably know, there are so many different types of knee replacements. So if you use a particular robot, you have to use that particular company's knee. And it's not one robot that you can use with all the knee replacements out on the market, which is really annoying because we don't know. The best performing knee may not have the robot available. But But these are the trends and the interests that are going on in knee replacement surgery. So, on that front, we are introducing a robotic-assisted knee surgery locally at the Nuffield Hospital. It's a system called Valis. I don't know what it stands for, it's probably marketing. Depew, J&J, one of the companies have made it. And their knee system is called the Attune knee system. We've used it. It has NJR data, which is pretty good. It doesn't have 15-20 year data because it's a relatively new implant. But we know the knees that are producing data at 3, 5 and 7 years, they will follow the trend of the older, more traditional knees as far as the outcomes are concerned. So as I mentioned, the outcomes are usually in revision surgery. Slightly crude outcome measure, but that's the best we have at the moment. But as we said, we're trying to introduce it locally to see if we can improve patient outcomes, patient experiences. So just to show you, so this is what's going to be in our theatre. Normally it will be just me and a scrub nurse and an assistant with a few tools available. Now we're going to have this. So the separate bits on this. So these two, that arm there has antennae which actually pick up the knee movement. So the patient's lying on the operating, they pick up knee movement. Then it's fed into that, which is then fed onto that, because you have that on one side. So if the patient is here, that will be on that side. And this is the robotic assisted arm, which is attached to the operating table. And then this is separate here, so that the surgeon can look there, or depending on what they're doing. As to they don't have to always keep turning their head around to look at the screen as to what they're doing. And this thing here, so this is now attached to the operating table. This saw, the robot doesn't do the cutting. The surgeon still has to hold the saw, but it helps control it. We like to think we're quite steady, but I don't know if when we do DIY or something, the hand can shake and all sorts of things. So, excuse me, not that. But it's interesting. I worked with a vascular surgeon. He used to smoke a lot, and if he hadn't had a cigarette, you start getting shakes. So in between cases, he would go and have a cigarette. In those days, when you could, in theatre changing rooms, not changing rooms, in the coffee rooms. And then sometimes his hand would shake like that, and you think, wow. So
probably because he needed a drink as well.
Probably. So this is a little bit of a close-up. So this is our patient. We make the cut as a normal sort of skin incision, and these are extra pins that are put in the femur and the tibia. So these little things have got antennae, which then feed information, onto that sort of T-bar thing that was there. And then that sends information to this. And then the surgeon holds this to try to make accurate cuts. So this is the theatre setup. So in our planning, we've decided this is how I want to do it. This is how I want to put the knee. So when we were talking about different alignments and things, you can plan all of that, and then get the robot. Surgeon still holds the arm, but it will hold it and theoretically more steady, and not go beyond the boundaries of where we want to be doing the surgery. So normally when we do surgery, there's an assistant holding retractors to keep all the soft tissues out of the way. The idea with this is that it wouldn't go too far. You still need to be able to do a new...
Do you have to do this under GA?
Sorry?
Do you have to do this under GA?
Yeah, it's still painful. Well, it doesn't have to be a GA. You can do it basically pain-free from here downwards.
Okay.
So, on the whole, the way we do total knee replacement is a sort of a spinal anesthetic.
Yeah.
From waist down, completely numb, and some sort of sedation.
Yeah.
which can go up to a GA.
Yeah.
Can I just ask, how do you feel about this sort of thing? Because it kind of feels like it's taken away a lot of your own skills, you know, and then if everybody goes down this route and then there's an issue, are you going to have the competencies to then be able to go back to doing it, you know?
So the interesting thing, all of this is, anybody have a cholecystectomy? No. So when I was a boy, we used to do it open cholecystectomies. And I remember holding a retractor for Mr. Goodman, the great surgeon who's just retired recently locally. I was his SHO, holding the camera while he was learning laparoscopic surgery. So now, almost nobody does open cholecystectomies. So we need to learn to do the standard knee replacement. We just learn in a different way. So, because that has happened, it's like arthroscopic surgery. I've seen one surgeon do an open ACL reconstruction and one surgeon do an open meniscectomy. And the rest have been arthroscopic. I've never done an open ACL or an open arthroscopic, open meniscectomy. But a lot of us here might have those great big scars from a meniscal surgery. You know,
I have one of those.
Yeah. So that's the point. But I think it's just how. So now the new generation of people. I mean, I'm not sure whether this is a real goer, but this is where the interest is. They will learn on this from day one.
So does the robotic arm like keep you in the right sort of angle?
Yeah.
And so are you just basically like pulling the trigger, so to speak, on the
So there are different sorts of robots. So this particular one, the surgeon does most of the cutting and controlling where I want to go. There are some others that if they hit or on the plan that it doesn't show up very well. Yeah, so this shows up here. So if I want to cut at this angle and that angle from front to back, the robot will make sure that the saw blade doesn't go beyond that. Because freehand, I'll put a retractor, but I can go all the way back. And as you know, there are neurovascular structures at the back and vascular injuries can happen. Rare, but they can happen. And this one here, so that is a cut at the front of the femur. Freehand, we can cut up here, so in thin air, or cut into the femur. And that's called notching. So you take the anterior cortex off. That's not good. So the theory with this is that it will be much more accurate. Jury's out, but the theory seems to be so we can place it much more accurately. But I think it's worth trying. We can't stand still and say, this is how we've always done it, you know. And as long as we follow them up carefully, patients are fully informed. Sadly, some of this is done more for marketing purposes, particularly in the private sector. We'll offer you this fancy robot and all this stuff. And that thing I was telling you about, the resurfacing, that's a private surgeon. And in the same region, I don't know if it's Southampton, in the old days there was one surgeon who was promoting something called the Ferrari of knees. And there was an implant called Next Gen High Flex Mobile. But he called it Ferrari and it was in the Daily Mail. And a patient came to me with a cutting, I want this knee, I said, go to Southampton.
Who doesn't want a Ferrari?
I mean, I don't, I'm too low. And I think they're ugly.
So is there just one standard knee?
Sorry?
Is there one standard knee or are there?
So there are dozens of them. Different sorts of total knee replacements. There are some more and more now, so the newer ones are coming out. There are older ones who have stood the test of time, who've had 10-year results, 15-year results. So there are probably a handful of those. There are quite a few newer ones. And the beauty of the NGR is because now we're collecting data, we can sort of safely say, okay, the trend is good or bad. If it's showing bad trends, it gets stitched quite early on. And when we make a decision, so in my formative years, if I wanted to start, and I would recommend a surgeon starting now, choose an implant with a track record.
So what about 3D printers?
There is a knee which is being promoted, so they take x-rays and scans of your knee, for instance.
So I thought your Kane machine that you've got here.
It hasn't come to that yet. But that's another thing, because I was thinking because we're doing resurfacing, and that thick piece of metal, I know I've cut it and I've replaced it. Wouldn't it be nicer if we, I don't know, something like graphene, this very intensely hard material, just like a coating over the worn surface. The material, that's got to change. And how? So individualizing the question about individualizing these, we don't know what the results are going to be. Because most of us, we want safe, tried, tested. And really, the newer things, I'm sure they'll come. 3D printing is being promoted. It's not 3D printing, there is an implant called Conformis where they try to sort of, it's called a knee in a box, so basically your knee will make it for you specifically. But then you just wonder, what's the manufacturing like? What if it's slightly different? The one that they produce. But they seem to be working. So, before we get there, yeah.
Sorry. That machine, could you use it to plan on the MRI images?
No.
Or do you have to plan on the MRI images and then move it on?
So the interesting thing is there are different systems. So this one we do on plain x-rays. And in fact, you know those markers that are on the knee? So one of the ways is the sensor here detects the knee movement. So there's like a pencil or a pen. You sort of draw on the end of it. So it's an opened up drawer here, and that then sends detailed information to that. So then from there it's able to create that plan. We don't need any special imaging. There are other systems where you need CT scanners. So then we send a CT scan to the company. The company then come up with the plan. Then we tweak the plan, and then we do the operation. The beauty of this is we don't need any of that. So this is a more advanced system. But then, you know, somebody might come up with even more advanced system. The reason I like this one is I don't have to get a CT scan, I don't have to send it to the company. Just go there on the day, plain x-rays, scan the knee, and then we know. And then we can draw where we're going to make the cuts. Anybody want one? So that's what's coming, and I'll tell you about my results, and then we can have questions and discussion. Otherwise, I could go on about this. So, results. So, interestingly, today I was doing clinic. I had 3 patients. One who came and went and wanted a phone call because I sort of said, I'll do a partial knee replacement. And he's American origin, and he wanted a scan, and he wanted all this, and he said, there's a knobbly bits, how are you going to deal with those? And simply just saying, I'll be able to do it wasn't enough. Because I said, well, I didn't say it, but I thought, this is my job, that's what I do, and I can do it. And then he sort of said, why are you doing half a knee? Half a job. You know, why not do the whole job? So 3 people today. It's unusual, but I think in the region we have sort of educated the population that it's not half a job, it's doing the right job for the right patient. And then they want to know, what are your results? So I looked at my results. I was preparing this a few days ago. So I don't know if you can read this. CLR appendix. CLR stands for consultant level report. So we get a report of our results, which general population doesn't know, but then I discuss it with my appraiser at the end of the year, so they know what we get up to before we get appraised, or they should. So over the years I've done quite a lot of knee replacements. So the interesting thing, often people talk about mortality data, total knee replacement data, partial knee replacement data, and patellofemoral joint replacement data, because there are different bits that we're doing. So in the last 5 years, unfortunately, I've lost 1 patient out of 706. When they say linkable primaries, they can link them to me that I did them. And the expected was 1.35, so slightly better, but it's still sad that although when we consent people, some of my colleagues sort of say complications including up to and including death, and I don't like that. It just scares me just saying it. And somebody who's vulnerable want me to do the operation. I don't want to scare them even further. You know, if they die, it happens, and all of us are going to die. But just to scare them, to sort of think this is what could happen. I think I don't like it, but people do. So that's the mortality. Revision of all knee replacements, partial, total, whatnot, in the last 10 years. I've done 1,500. There should have been, if we are talking about expected numbers, 27, and I had 14. This bar chart here, this one is the expected line. This side is slightly better. That side is worse. And if you're one of these whites, these are bad outliers. Don't know what that means. And if you're on this side, that's good result. So in the last 5 years, all revisions, all knees, 728, one revised. Should have had 6.8. So this is quite reassuring for patients because then they can sort of say, yes, you're not doing half a job. Maybe you're doing the correct job. So revision, total knee replacement. So we divided that 5 years, total knee replacement in 10 years, 832, expected 12.8, and actual 7. And unicondylar knee replacement in the last 10 years. So I've done 639. 18.3 should have been revised. How did they come up with these figures? They look at all of the outcome data. I'll show you a little bit on the next slide. So I've only had 6. So that's 1% in 10 years. I'll take that. And if that's what, because then that convinces patients, actually, we're doing the right thing. So this American guy wanted to have an MRI scan. And I found it really difficult justifying, because X-ray showed he's got medial compartment arthritis. And he said, I want to understand better. But I said, I practice medicine the way I want to practice medicine. I would find it uncomfortable doing an MRI on you, because I don't think it's necessary. And he was a private patient. And I thought to myself, no, I vocalized it. So I said the easiest thing would be not to have this discussion. You want to have an MRI scan. I fill in the form, you have an MRI scan, and I make another 150 quid. But I couldn't do it. And I said, I'm not doing it. Either take my word for what I do, or go and find somebody else. Because we can't practice medicine the way other people want you to practice medicine. Practice medicine the way you want to practice medicine. So I said, if I do an operation and it goes wrong, I still don't think my peers will criticize me for not doing an MRI scan. He could be number 7, but I'll take it. Patellofemoral, we don't do that many. So I've done 3 or 4 a year. I do a lot more now. This is, when you first start, you think, do I want to do them? You've got to be cautious. So only one of them has been revised so far. So fairly good results for our conventional knee replacement. So you say, how am I going to improve that? Well, that's the tricky bit.
Can patients access that?
No, because this here. So it says standardized revision ratio mean. I downloaded it 3 days ago. For the last 5 years, overall revision, so basically partial, total, whatever knee replacements we do. And these are called funnel plots. I don't know if there are statisticians amongst you. So each dot is a surgeon in the UK. And this is my data over the last 3 years. So that's my dot over the last 3 years. Number 1 is what would be expected. I'm averaging all out, so no surgeon admits to being below average, but all of these are below average. But it's like sort of when you work out an average, 50% got to be below average, isn't it? Or 49.9, whatever it is. But that's what it is. However, if that is the standard expected line, this two here, that blue line is 2 standard deviations, so 95% from the norm. So we think that if a surgeon does surgery and the outcome or the revision rate is within 2 standard deviations, it's okay. Maybe or may not be okay, it's okay, because statistical quirks. This line here is 3 standard deviations, so that's 99.8%. So if one is here, there isn't anybody here who's so good. But my data is here, and there are only 2 surgeons who have better outcomes than me, and they do more than me, so that, I don't know. My aim is to try to get that's my proviso. I'm on the podium, but I want to be number 1.
Is that just for knee surgery then?
This is knees. I just do knees.
That's not for hip surgery as well?
Oh, this is just me, hips. But there is an equivalent for hips as well. So hips, knees, shoulders, ankle. Shoulders and ankles, they haven't really got the data. Hips and knees is what we really started with.
Spine is also on the joint. Spine has...
Oh yeah, they have something else.
Something.
But yeah, they do. But it's not like this. So the NJR was essentially, that's brick spine do that, and NJR essentially started for joint replacements. And then the others came on board. So that's why shoulders, elbows, ankles, they're more of an infancy. They don't do many numbers as well. But in 10, 15 years time they'll have the data, but we have that already. So the reason you were saying, why don't the public know about it? So these red dots are guys who are worse than 99.8%. So they're outside, they're called outliers. Whatever the reason may be, they would...
Do you know who they are?
You scroll over the dot and find out who it is.
We know there is one surgeon in the county who's dead. She'll remain nameless. Because they could argue it's their livelihood. Who'd want to go to one of them? So when you guys send a patient in, you have no idea where they're going. And when GPs send patients, normally they would say, he's a good bloke. Good blokes are usually good blokes in whatever ways. We have some girls now as well, so it's all right. For years we had no female orthopedic surgeons in the county. Ridiculous, but we do. So the point is, if general public knew about it, nobody wants to go to below average surgeons. You could say, well, they're up the game. But there'll always be some who are below average, just because of the statistics, the way the statistics work. That's where those crude numbers would be helpful. But if somebody is there, it becomes very difficult. How do we deal with them? And the way we deal with them, the National Joint Registry write a letter to the chief executive and the surgeon and say something's not right. People don't go there overnight. So for the last 3 years, I've been hovering around here, 1 or 2. Even if I ended up having 10 revisions this year, just because I had a bad year, it's unlikely I'll end up here. It's sort of gradual. So the reason for publishing this every year is that the surgeon can monitor their activity and say, I'm going this way or that way. Do I need to look at my practice, modify my practice, do something different? But the people who run the NGA, they used to do a talk to the surgeon saying, right, if you're an outlier, we talked about different sorts of implants. Choose an implant which has the best outcomes. So there's one variable. If you want to become an outlier, do a different implant every other day, because you never get used to it. Because there is a bit of a learning curve to whatever we do with human beings, even the robot. I'm going to operate the robot. They did introduce a robot in one of the local private hospitals and taken it away because they had issues. So it's not that easy, but this is the data. And I think this helps patients knowing who they're seeing. So I have my NGR web page on because they sort of say, why are you doing what you're doing? What are you advising? So I have lots of tabs open, they can have a look at it. So my American friend, he's going to stick with me. I managed to convince him. He saw my data, but he still went home and sent Karen pictures of the knee x-ray and said, what's this knobbly doing? What's this knobbly doing? And he wanted to have an MRI scan. So should have I done an MRI scan?
Do you want to take pictures of that on though? Because if you've got somebody who's that pedantic before you go, you're guaranteed that somebody's going to go wrong, aren't you?
You can't pick easy ones.
Yeah. If they're paying, you can give them to the outlier.
No, but I want to make them even better.
Yeah.
I've taken all comers over the years, you know, the slim ones, fat ones. There are doctors who say, oh, you're too obese, we're not going to do it. I mean, that's, you know, you can't sort of say smokers, we're not going to treat the coronary artery disease, are we? They've got coronary artery disease because they're diabetic or smokers. Tough. You're obese, you've got dodgy knee, put up with it. You know? But we can help them, we can advise them to do something about it. But we know it's very difficult to suddenly change your habit and say, and then we can't always. I mean, yeah, you're right. Sometimes, I mean, I did tell him to go and see somebody else, but I wasn't going to change my stance. And either he sticks with me or we go somewhere else. You know, losing one patient is probably, as you say, we probably will do wrong. But I know I can sleep easy. I did it the way I think it should be. So the questions, I mean, I know we talked about knee replacement. Knee replacement is common, and that what I suggested is current and newer than most of us are aware of. And we're going to try the robot locally. We will follow it up, and hopefully, so the revision rate I don't think is going to be hugely different, because we already have good revision rates overall. But the satisfaction rate, which is different, might get better. Hello?
Are the plain film x-rays taken weight bearing?
Yes.
And do you do both knees for comparison?
No,
Why not?
because it's for the same reason that this guy wanted to have an MRI scan. So if it's clinically indicated, that's the one I'm interested in. But in theory, you know, if you x-ray both of my knees, they're both probably a bit warm.
Doesn't it help with pelvic alignment?
And like the phenotype.
Yeah,
Phenotype, yes.
and the weight bearing.
Yeah, so I haven't got to that stage yet, because it may come to it. So currently, the way I practice, I think weight bearing is important. So AP lateral standing, skyline view, and Rosenberg.
What's that?
So there are two. So Rosenberg view is a PA with the knee about 45 degree flat, and there's another one called Schuss view, which is 33 degrees flat. And the idea is, because when we do a standing PA, we're not really looking at the true joint line, because the joint isn't flat, it's sloped, 7-degree posterior slope. So if we do an X-ray that way, then we're looking truly at the joint line, rather than just front on. So that's why a Rosenberg view is very important. A lot of the times, I do a talk, I do a meeting, an MDT with our MSK colleagues. So they will do a standard X-ray, GPs or people out in the community. Often it's non-weight bearing. And then they'll organise an MRI scan. Maybe I shouldn't say this, you know, in this place, but I say to them, why didn't you do a Rosenberg view? It will tell me all I need to do. If you're going to send a patient to me, and you want me to treat them, unless you're concerned about meniscal or ACL or other issues, for arthritis, it's plain X-rays, and it's the correct views. So AP lateral standing, skyline, and Rosenberg. If I'm worried about their alignment, or if they're malaligned and they're a younger patient, I would do a high tibial osteotomy. So I'll change the alignment of them, not by doing joint replacement.
Is that then not really painful to do when you've got problems in the PF joint? Yeah, it's one that they kind of struggle to do.
Some of them do.
Yeah.
But you know, it's a short-term pain for long-term gain. Yes, sir.
It's quite an interesting experience about a year ago. I had a GP, 54-year-old female, and she had ruptured her ACL. And she was also due to have a knee replacement. And she said, when I see the surgeon, I'll ask him to repair my ACL as well.
Same knee?
And I said, yes. And I said, you won't need the ACL after, it'll be taken away.
Yeah.
She didn't believe me.
Yeah.
And when she had the operation and she reappeared, first thing she said, you were right.
Absolutely.
I knew I was right, but...
yeah.
And the question I was going to ask, if you've got a half knee, does the ACL stay in place?
Yes.
I thought it did. Yeah.
So, now, there are different sorts of half knees. You may have heard of something called the Oxford knee, which is what's called a mobile bearing knee. So the tibial plate is flat, and the plastic sits on it, which moves. And the classic teaching for the mobile bearing partial knee replacement is they must have an intact ACL. Because the risk is, as it's floating about or the knee is unstable, the bearing might dislocate or wear out abnormally. The partial replacement that I do is something called, which is fixed bearing, so the plate at the bottom, the plastic fits into it. It doesn't float on top. And the ACL is not so important for that. So partial knee replacement, for fixed bearing, ACL is not important. Mobile bearing, ACL is important.
Why would somebody do a mobile over a fixed?
So in the UK, Oxford Knee, they were the pioneers for partial knee replacement. And there were other surgeons who were using fixed bearing knees in the other parts of the world. And the Oxford guys are very smart and very intelligent. They did lots of research and they published lots of papers showing excellent results. So until about 7 or 8 years ago, that was the most commonly used partial knee replacement in the UK. About 6-7 years ago, the Oxford usage, overall numbers are down, but we're doing, overall numbers are up for partial knee replacement, but the percentage of the mobile market's gone down and the fixed bearing's gone up.
Is there any difference in like the range of movement of mobile versus fixed?
That was the theory that they produced would be better.
Yeah.
So overall, the fixed bearing movement is as good as mobile bearing, and the revision rate, all-cause revision rate for fixed bearing is better than the mobile bearing.
Mm-hmm.
So when I first started, I was the only one using fixed bearing in our area because I was young at the time and I worked with this guy who used it, and no, everybody else was using mobile bearing because basically the British Oxford influence. And I did my fellowship in Australia. And now, most of our guys in Gloucestershire are using fixed bearing knees.
Seems like it gives you a bit of a safety net.
Yeah. So I've used mobile bearing. I had one bearing dislocate. And they think that's okay because out of, I don't know, hundreds. But that's one too many.
Mm-hmm.
So I've never used it.
How long do you find they last generally for a partial knee replacement?
So you saw a partial knee replacement, 10-year data that I showed you there. So in 10 years, partial knee replacement, 639, 6 revised. So 1% revision, 99 are still going at 10 years. And most of us, I know we're living longer and longer. But
So if you do a revision then, would that be a total knee replacement after that?
Interesting. So sometimes if the what's called disease progression, so the medial side is okay or lateral, whichever side we did is fine, but the disease goes to the other side. I haven't done it yet, but there are some surgeons who would leave that one and do another partial on the other side. And there is also a procedure called combined. So you can combine patellofemoral replacement and a medial unicondylar replacement. and I have seen x-rays, which none of mine yet I might do it, where there are 3 separate bits, 3 partials, medial, lateral and patellofemoral. And why do we do that? Well, their rationale is that in all of that, why throw away good bits? So if the knee is functioning well in the lateral compartment, it's disease. So it's more, uni or a partial knee is a much smaller procedure than a total knee replacement. And the results are pretty good. And in here, so I do combine. So sometimes I combine the patellofemoral with the uni. Because when we do that, the ACL is intact. And if the ACL and PCL are intact, the knee will function better. Whereas in total knee replacement, we always cut the ACL. And there are some philosophies of knee replacement where the PCL is also cut. So in here, there are combined procedures as well, so they last. I don't, if they didn't last, we wouldn't do them, obviously. We would change practice because I don't want to go up to the red. But I'll retire happily because I don't think unless there's something disastrous happen, I've got a few years now, but to get there it takes a while.
So how long is your data going to be going for? Is it going to be like 25-year data, obviously?
I hope so. 20, so heavy.
Mr. Gosal, I'm a former patient of yours actually, but I've recently had a half a knee
Where was
in
it?
the
Yes,
other
I
knee.
know it was.
And
You're back here?
Mr. Oakley did it.
Oh, in Hereford.
Yeah. And the thing is, my ACL is intact, but what it feels like to me, and I don't know if this is possible, is that the ACL now is too tight, and I'm finding it difficult to get full extension. Is that possible?
No. What sort of uni did you have done? Oxford.
Uncemented.
Yeah.
Is that, yeah?
Yeah, the uncemented Oxford has good results.
Yeah. And it feels good, but it just feels that I just can't get into full extension.
That wouldn't be your ACL.
It wouldn't. No. So you just think it's tight tissues at the back.
Something's tight.
Yeah. It's a nice big
Because-
bacon cyst there.
No, it wouldn't be a big decision.
So
I mean, sometimes it happens, you work hard with patients as you're treating with it, just can't get the extension. And one of the things to bear in mind is that we always tell patients what their pre-op movement is. And that is almost what your post-op movement is going
I
to be.
agree. Yeah.
And in theatre, I sort of say, I managed to get it fully straight and fully flexed. And the patient comes along hobbling, you can't straighten it. And that's because I can stretch them while I sleep, instantly, muscle memory. It's been there, it's been contracting the capsule. We don't get rid of the capsule at the back. That's been going on for years. So it gets into that tight.
And the learned behaviour with the
And the
guarding
patient,
and things like that.
So if when you were asleep, I bet he could get it fully straight. Because if you look at his op note, he will say full range of movement.
Yeah. I mean, I think we would all agree that prehab is so important. We can get to patients before surgery.
So, my mum had a full knee replacement last year and she really struggled post-op with loads of pain and loads of difficulty. It's usually a very hard recovery time after a knee replacement.
So total knee replacement, I'm generalising, but on the whole it tends to be more. So I do, as you see, I do hundreds of them. And I always think, what a barbaric operation. Don't tell your mum, but so if that's the femur, that's the femur, that's the tibia. At the time of the operation, to cut the top of that, in the conventional way, we move all of that forward like that. Right? So there's a retractor here, there's a retractor here, a retractor. So just imagine, 2 or 3 inches. Basically the width of the tibia is moved forward so I can get to the back, to cut to the back. And that's going to hurt. So all the structures at the back are just pulled forward. And then, yes, I know we put them back in the right place, but that's going to be half an hour, an hour.
I have to say, I went home when my mum had her knee replacement, and as a physio, I went in, and I would say to patients now, expect 2 weeks of hell, and after that, once your clips and everything are out, things will improve dramatically.
And what's
But you have to expect the first 2 weeks to be hell. And I think if you're not, and you have to try and get it fully straight and straight to 90 in that time, and I think if you don't do that, and you don't have that expectation, you're not going to do well. I think it's really hard.
Absolutely. I think that's why in the old days we used to have home school, physio sessions telling people what to expect. Now it's just such a rush to get it all done. We don't tell them. I mean, we try to. I always say to them, for the first 6 weeks, you're going to say, God, why did I have it done?
That's basically what she says.
And then by about 3 months, you say, no, that was worth doing. 6 months, you say, Mr. Gosal's wonderful. And at a year, they're telling their friends, Mr. Gosal's the man to go to. Before that, they say, you need the other one? No, I'm not going to come to you. I wish I don't see you again. I know, I've heard it all, and that's what happens. And the other thing is, our pain management perioperatively is much better now than it was about 10 years ago. The anaesthetic techniques have changed, and the way we infiltrate the knee with local anaesthetic is much better. So hardly anybody now wakes up with pain. A few years ago, in the recovery room, you'd get a call to theatre saying, Mrs. So-and-so is still in pain, he needs to rushes and give some morphine or whatever they give. And that's a lot better now. So I think if your mum woke up if a patient wakes up with pain, I always worry that they're going to be a candidate for RSD, reflex sympathetic dystrophy, which is pain. It gradually gets better, but that's very difficult. And then they don't want to move it. And then it's that vicious cycle. It's painful, they don't want to move it. They don't want to move it, you tell them to do physiotherapy. And then the physiotherapists tell them to push it. Then it gets more sore. So the most important thing is education and pain relief. And then they'll work. And I always concentrate on extension. Everybody, the patients worry about flexion. I said the most important thing is extension. Because you can't walk like, bent leg and a straight leg. And the other thing is if a patient has 2 bent legs and you replace one, the replaced one will be bent. Because whatever you say, they're going to walk with one straight leg, one bent leg. In an ideal world, if the patient's fit enough, we should do both at the same time.
It's always in that one.
Because if you do one, they're going to end up with a stick.
Have you ever done 2 at the same time?
Yes.
How successful do you find?
Good. So it's about choosing the right patient. So they've got to be physically fit, i.e., they can put up with a little bit of pain, but also they've got to have good cardiovascular reserves. So the anaesthetists are going to be happy that the patient's going to be on the table for 3 hours as opposed to an hour and a bit.
So how long is an hour and a bit?
Could you tell me a little bit, please, about non-cement? It's interesting now.
Cement? Non-cemented. So we'll use this as an example. These things here. The implant, say, this could be cemented or uncemented, for instance, to fit it onto the bone. This white stuff is probably cement. However, the way these implants are made, they put a little bit of, for want of a better word, grit, metal, it's called grit blasted, so they make it a little bit rougher. Or sometimes they put something called hydroxyapatite coating on it.
So the bone grows.
So you make a cut, it sits on that, the bone grows around it. So there isn't any cement, but it's just metal which is prepared in a different way so that the bone can sort of stick onto it. Because if it's shiny metal as on the femur side, and the shiny side, it's not going to fit. So it's slightly roughened so the bone goes into it.
It seems like is it just the picture that makes it look like it's such a small bit that goes into the bone, or is it actually quite...
This is sort of an old implant. So if for a partial knee replacement, it's a small bit. For total knee replacement, this thing here.
Did the hips not used to have holes in them when they were non-cemented, the stems?
Yeah, so there are so many different ways. So basically they've tried, so the ones with the hole, they're a nightmare to revise because if the bone grows all the way across, then you can't get them out. You have to destroy the femur.
Okay.
So, but we do. But yeah, that's what I mean about materials and things, they're evolving all the time.
Is non-cement offered on the NHS?
Yes. So, partial knee replacement, the guys who do uncemented implants, I don't. uncemented. So the Oxford Uni is, their cemented Oxford Uni results weren't that great. They would admit to it, but they stopped doing cemented. So now they're doing uncemented. And the uncemented seem to be better. So the guys who've used the Oxford Uni now is uncemented.
Why would you get cemented? Sorry.
Results? As I said, the implant design, so the one I use, their design is meant to be fixed onto bone with cement. And actually, from the surgeon's point of view, there are different perspectives. Sometimes you do the cut, bang the uncemented thing. The disadvantage, before I go, disadvantage of uncemented is they get more fractures. So, so this little thing here has to be fitted into the bone. And to make it seat properly, you don't want it to be loose. You want a tight fit. And how tight is tight? You know, sometimes you sort of think little hammer, big hammer. So fractures here are quite common, not quite common, more common in the uncemented than cemented.
Whereas you don't have to be as brutal if it's
Yeah,
cemented.
yeah.
Essentially, do you just bang it in?
That's what happens with the uncemented.
The metal is just being forced into the drain.
Yeah, yeah. Well, you make a little trough in it, but it's a sort of tight trough.
Big hammer.
It's slightly bigger. I always use, there are two types of hammer, the heavy hammer and toffee hammer. I use toffee for tibia, so always use a soft one in the tibia. But, yeah.
But what about long-term osteoporosis, you know?
So, the bone being loaded, osteoporosis is not an issue. If you don't load it, it'll be an issue. And more often than not, the implants loosen, but it's not because of osteoporosis. What happens is the implant will move, or more likely often is the plastic which produces debris. Even the best polyethylenes produce some debris. The debris floats around underneath, and then it starts creeping into crevices, and that's called polyethylene disease. So osteoporosis is not an issue. Right. Anything else? Any other questions?
How heavy are they?
They're not heavy enough for the patient to say, I put on weight.
My nan had hers done probably, I think she was in her 70s. But she's always like, oh, my leg is so much heavier.
Yeah.
And I'm like, I don't think it's that much.
The muscle.
It's the feeling.
Yeah.
In fact, I mean, if she was 4'2" when you put one of these, they're probably about 500 grams. The femoral side is really very heavy. Not very heavy, but heavy. The tibial side is quite light. Depending on the implant, often they make it made of titanium. Titanium is quite light.
A lot of patients used to say actually it feels really mechanical. That was the thing. You know, it feels good but it feels mechanical, and you're like, I don't know what that means, but a lot of people say it.
Yeah, it's because they
It just
clunk a bit. They think when he clumps. And I always say to them, so if I shake my left leg, which is not replaced, it doesn't clunk. But I'm still moving cartilage and cartilage. It doesn't make noise. If you sort of tap metal or plastic or metal on metal and there's a little bit of movement, it will clunk. It'll make a noise. I mean, there are other reasons for clunking, if patella maltracking, or, but often they sort of say, look, it makes a noise. And I said, shake your other leg. It moves side to side, but it doesn't make a noise because it's cartilage and cartilage. This one is because it's metal on plastic. And I think they always, patients say, it doesn't quite feel like my own knee. Whereas for the partial, they will say, oh, I've forgotten I had a knee done.
What about running? That's the thing, we all want to be able to run.
Yeah, so why would you want to do it?
I think I have to ask them, when was the last time you went running?
Yeah.
Oh, about 20 years ago.
So, I had to say simple things. You can do what you like. There's no restriction as far as I'm concerned. They want to say kneel? No, kneel from day one.
Can I kneel?
Yes, kneel from day one. And if they're fit enough to kneel before, they'll be fit enough to kneel after.
Even with uncemented?
Any.
Is it more so the nerve fibers getting pinched from the metal against the surface of what they're...
So the reason they can't kneel is sort of, if it's you're kneeling on metal and the lever arm, the extension, it is not as efficient. So work on your quadriceps, you'll get better. And I tell them to start kneeling as soon as, because they always ask it, right? As soon as you've had your knee, the wound heals, start kneeling. Everybody's sore. I've done an operation, it'll be less sore if you start kneeling. So kneel on a pillow, kneel on a cushion, kneel on a bed, practice. And it'll get better. So there's no restriction. They sort of say, oh, it's painful, am I hurting, damaging it? You're not damaging it. So the running argument I use, I say you can do what you like, because there's no restriction. But you have to sort of think, you've got metal, and you've got soft bones. So I've got a hammer, and I start tapping on the table. So if a metal keeps tapping on that, what's going to happen? The likelihood is the metal might, might get stronger, or it might give way. So why would you want to do something silly? You can do it if you like, but the risks are high. It's like people think, I want to go skiing. Go and ski. When you get a paraprosthetic fracture, it'll be fun fixing it. It's just silly, isn't it? People, they ask questions and they do silly things. If you want, skiing is riskier. I don't discourage people from doing anything. It's not an implant that's the big problem. It's what sort of personality are we? Do I want to take risks? And as surgeons, we'll fix anything.
How soon will you cycle after the knee replacement then?
As soon as it's healed.
Possible.
So, there's a couple of weeks, the wound's healed, sit on a bike, but of course you don't want to feel like sitting. So within a few weeks. So I say to them, once the wound is healed, and you can sit on a bike and do a revolution. And they can't do a revolution because it doesn't flex fully. So then you say, raise the seat and gradually lower it as time goes by. Because then you're flexing less. So if you lower it, so the whole point of doing joint replacements is to try to let the patient enjoy their lifestyle. And a lot of the times when we restrict people, it's sort of folklore, tradition, or treating the surgeon. I just feel comfortable. But the implant never fails. It's the body around it.
Do you have to replace the meniscus very often?
Meaning?
Well, you put a sort of poly...
Well, there is something called meniscal replacement, some trials going on. So in a young person they've had a meniscectomy, from cadavers, you can put meniscal replacements. What you're saying is about the plastic changing and wearing out. So I'm just thinking, I think in my memory as a surgeon, it fades as time goes by, doesn't it? I don't think I have ever changed just the plastic, because the quality of plastic is so good that they wear, but they don't fail, so we just change the plastic. There is one proviso. Sometimes if the patient has an infection relatively soon after they've had a knee replacement, then the metal is fixed well. And then we do something called a DARE procedure, debridement and implant retention and antibiotics. So basically move the plastic so you can get into all the crevices to wash it all out. Lots of antibiotics, and then put a new pair in, but not for wear. Oxford unis, they dislocate. Been in there and put them back in. That's what I don't do.
So you said you do high tibial osteotomies for like if there's if the angles.
Yeah. So
right.
So I don't know, a youngish person, relative age, they've got medial compartment degeneration, and there are degrees of medial compartment degeneration. So a 40-year-old comes along with medial compartment degeneration. They've got bow-legged. We'll do an osteotomy to straighten it. Slightly go past the straight, to offload that compartment, to load that compartment, and then that will last. It's not going to last forever, but it'll buy them 10-15 years of
Before
active lifestyle before they need it. And similar, if they've got a lateral side, we do a femoral osteotomy. So one compartment.
What age do you like doing the replacements on? What's the youngest you would do any replacement?
Depends on the condition. Osteoarthritis, there's a real my youngest patient was a girl in her 20s, but she had rheumatoid arthritis, so that's a different disease.
But in an osteo?
In an osteo in their 40s, I have a girl whom I've known since she was a teenager. She's 33 now. And she needs a knee replacement, and I'm not doing it. I mean, it's good to it, but that's just, technically, that's not the difficulty.
Is this the one with rheumatoid arthritis?
No, she osteoarthritis. So she ruptured her ACL when she was young, then it failed, then she had meniscal problems. I've done an osteotomy, I've done an ACL reconstruction, I've kept going. She's a friend of mine, we come. But now the knee's so bad. Even when I first met her, I presented her at a meeting and I said, guys, how old is this patient? Somebody said 65, 70. That's what the x-ray looked like when she was 20. So we kept her going by doing these procedures.
So you said that you won't do a replacement on her?
Just because it will need multiple revisions. I mean,
But what kind of quality of life does she
it hasn't reached that stage. And she comes and complains and I talk to her and we come to a mutual arrangement and then she goes away and comes back for 6 months.
Does she have like various braces, like
She's tried braces,
yeah.
yeah. She has an offloaded brace. She's slightly overweight. She works as a physiotherapy helper. So she knows, she manages. I mean, I'm saying I won't do it. Obviously, if she comes along and says, I'm taking painkillers, I can't sleep, I can't do this, then it's a relative thing. I'm not making her suffer just because of age. I can manage it for her.
Typically, how long do they last? Sorry.
Typically, so
Yeah.
different ways of looking. 90% of people who have joint replacement, all comers, leave Earth with it. So it depends how old you are. If you're 55,
You may end up.
30 to 40% chance it will be revised. If you're 70 and you have a knee replacement, about 4 or 5% chance it will be revised.
Okay.
So younger patient, higher revision rate. Overall, we used to say 10. I'm quite happy saying 15 years it'll last. And the data shows that.
Why does the metal and plastic need to be replaced? It just wears out from mechanical.
Yeah, so, I mean, it's trying to find the perfect material. They're a lot better than they were when Charlie started doing hip replacement. They made a Teflon. You know, the plastic bit. That just wore away quickly. So that's what I mean. When I first started as a registrar, the plastic used to quite regularly wear. One of the things was manufacturing. So it was called cross-linked polyethylene. Now it's highly cross-linked, so whatever chemical bonds they do. And then it was about sterilizing the polyethylene. So in the old days, they would sterilize them in oxygen. And now they use inert gases or in vacuum. If the plastic is sterilized in oxygen, the plastic gets oxidized, which would fail, become brittle. It's a bit like, you know, iron becoming rusty. So we change materials, technology is improving. So I don't know, I'm sure it'll get better. It's got a lot better since I've been practicing. Anything else? Anybody else? I think that's about it.
Okay, thank you.
Thank you very much.